So, good evening, everyone. So today's our session is on top vaccine papers by Dr. Kiran. So, before we begin, let me set a stage with a quick note on why vaccines are so important. So, vaccines are one of the greatest achievement in the modern medicine. They protect us from a life-threatening infection as well as prevent the spread of diseases in the community and saves millions of lives every year. So beyond the health, they also reduces the healthcare cost and strengthen the society by preventing the breakouts or breakthroughs. From the eradication of smallpox to the near elimination of the polio, the rapid development of COVID vaccines, history has shown us the vaccines are not just a medical tool, they are the foundation of global health security. So, for this a very important topic, we are going to have a session today by a Dr. Kiran. So he has completed his MBBS from Malakandra Orthodox Syrian Church Medical College, followed by his MD in a general medicine from a Pondicherry Institute of Medical Sciences. Dr. Kiran went on to a specialization in infectious diseases, completing his fellowship in a general infectious diseases from CMC Vellore, as well as fellowship in a clinical infectious diseases at the Amrita Institute College, Kochi. So he also pursued a postgraduate diploma in HIV medicine from IGNOU, and he has his expertise in infectious diseases and a insight. So he's going through a very well-known topic of top vaccines papers. So let's start our session with Dr. Kiran on a top vaccines papers. So over to you, sir.
Yeah, thank you. So first, I'd like to thank the Federation of Clinical Pharmacists India for giving me this topic. So as you know, it's the vaccinology is a huge area, and there's a large number of studies coming out. So I'm not going to go into into deep statistics and immunology. I'll be concentrating on topics that are of importance in daily clinical practice. So I'm in the Department of General Medicine. I run the infectious diseases OP and the general medicine OP. So what all things we see on a daily basis and how vaccines have helped us in that. So I'll be going through around 5 to 6 papers. So the first one, this is my disclosure information. So the first paper that I've taken is actually from the Vaccine Journal. It had come out in 2021, so it's around 4 years old. But why have I taken this now in this year? So the name is a trial to evaluate the safety and immunogenicity of a 20-valent pneumococcal conjugate vaccine in populations of adults above 65 years of age with different prior pneumococcal vaccination. So as you all know, in India right now, we have the PCV13 and the PPSV23. So that is what we have been giving in our OPs after transplant, etc. We don't have the PCV20. The PCV20 has just come to the country, and maybe by the end of this month, we'll be using the PCV20. So that is why I've taken this topic. So what a small talk on pneumococci. Streptococcus pneumoniae infection, it causes bacterial meningitis, bacteremia, non-bacterial pneumonia, pneumococcal pneumonia, and it was the leading cause of LRTI, morbidity and mortality in 2016 in 195 countries, and it contributed to around 1.2 million deaths. Most invasive pneumococcal disease is caused only by a subset of more than 95 known pneumococcal serotypes. Pneumococcal vaccines that target the polysaccharide capsule of certain serotypes are available, and they include, like what I said, the polysaccharide vaccine such as a 22-valent pneumococcal poly, that is the PPSV23, and the conjugate vaccine, that is the PCV13. So in our daily clinical practice, this is what we use. The PCV13 is the conjugate vaccine, while the PPSV24 is the unconjugated polysaccharide vaccine. The PPSV23 is limited in that it elicits a T cell independent response which provides the short-lived protection and does not induce immunologenic memory. So that is important. So the PPSV23 has a short-lived protection and does not induce memory. In contrast, the PCV contain polysaccharides conjugated to an immunogenic protein, resulting in a T cell dependent immune response that generates immunologic memory and establish an immune state that allows for boosting of immune responses upon receiving a recall dose 3 to 5 years later. So suppose a patient who is immunosuppressed and he comes to our OP, what do? We start them off with a PCV13 followed by a PPSV23, which has to be vaccinated every 5 years because the PPSV does not have memory. So the PCV20 contains the same components of the current PCV13 plus conjugated polysaccharides of 7 additional serotypes. These additional serotypes were selected based on the relative prevalence as a cause of pneumococcal disease, their generalized geographic distribution, and other factors that support their inclusion, including the presence of antibiotic resistance, greater disease severity, and invasive disease potential. The 7 additional serotypes are in common with the PPSV23. The global burden of adult pneumococcal disease due to these 7 additional serotypes is substantial. So that is why this has been included. So given that many older adults may be pneumococcal vaccine experienced and could benefit from administration of this expanded PCV, the phase 3 study was conducted to describe the safety and immunogenicity of the newer PCV20 administered to adults 65 years of age and above who's been vaccinated with either a PCV13 or a PPSV23 or both. So this study is basically to see the safety and immunogenicity of the newer PCV20 vaccine. When I say newer, this has been there in the US previously. It has come to India just now. So the study design, it's a phase 3 multi-center randomized open label study conducted from February 19 to February 2025 at 33 sites in the US and 8 sites in Sweden. So evaluated the safety and immunogenicity of the PCV20 administered to adults with prior pneumococcal vaccination. So adults above the age of 65 were enrolled into 3 cohorts. The first cohort included participants who had received PPSV23 previously but had not been vaccinated with PCV13. So, or above 65, those who have received PPSV23 came in the first cohort. Second cohort, those who received the PCV13. Third cohort, those who previously received both the PCV13 followed by the PPSV23. The participants received a single dose of the PCV20, PCV13 or PPSV23 at the first visit based on their cohort enrollment. So basically, the center-based interactive response technology system was used to randomize 2:1 participants with prior PPSV only to either PCV20 or PCV13 and those with PCV13 to only PCV20 or PPSV23. And all participants with prior PCV13 and PPSV23 to receive the newer PCV20. The PCV13 in those with prior PPSV23 only and PPSV23 in with prior PCV13 only served as a control vaccine for safety assessment. The study was not blinded. Blood samples were collected before and 1 month after vaccination from all participants. So what they've looked at is the opsonophagocytic activity titers for the immunogenicity assessment of the 20 vaccine serotypes were measured in the sera of the PCV20 recipients only. So objectives were safety was to describe the safety profile of the PCV20. Endpoints included percentage of participants with prompted local reactions, systemic events within 10 days and 7 days after vaccination, and percentages of participants with adverse events within 1 month of vaccination and serious adverse events and newly diagnosed chronic medical condition within 6 months of vaccination. So these were the endpoints, whether there were any local reactions, whether there were any systemic events, whether there were any adverse events, whether there were any serious adverse events and whether any newly diagnosed chronic medical condition had come. The primary objective for immunogenicity was to describe the immune response to PCV20 in adults who've been previously vaccinated with PPSV23, 13 or both. So they were assessed by the OPA and OPA geometric mean titers 1 month after vaccination. The secondary objective for immunogenicity was to further describe the immune response in the 3 cohorts. We'll be going into that. So this is how they had cohorted it. So a total of 875 participants were enrolled into 3 cohorts based on their previous pneumococcal vaccination. So here in the first cohort, above age of 65, 370 people were enrolled with a prior history of getting only the PPSV23. In the cohort 2, 375 people with only prior history of PCV13. Another 125 people with a history of both PCV13 and PPSV23. So in this cohort, again randomized into getting PCV20, and here as the control was the PCV13. Here PCV20 and the control was the PPSV23. So this is what I just explained. So coming to the safety, that is the local reaction and systemic events. The percentage of participants who reported local reactions within 10 days and systemic events within 7 days after the PCV20 were generally similar across the 3 cohorts and were also generally similar to the corresponding control groups within the cohort with prior PPSV23 and cohort of prior PCV30. Mild local reactions and systemic events were mild or moderate in severity. The most frequently reported local reaction was pain at the site of injection, and most frequently reported systemic was muscle pain. Fever was reported after PCV 20 by 2 patients with prior PPSV 23 and after PPSV 23 in 2 patients with prior PCV 13. Now coming to adverse effects, in the PCV20 groups, the percentage of participants reporting adverse effects within 1 month after vaccinations were low and generally similar across 3 cohorts and were similar to the percentages after PPSV13 and PPSV23. 2 participants reported immediate adverse events like dizziness and anxiety, and 1 with dizziness after the PPSV23 in the prior PCV group only. Reports of any severe adverse effects from vaccinations to 1 month after vaccinations were infrequent for all vaccine groups. The majority were considered not related to study vaccine by the investigator. The percentages of participants who reported any serious adverse events or any newly medical condition within 6 months after vaccination were very low in all vaccine groups and were consistent with medical events or conditions that might develop in individuals of this group. No serious adverse events or newly were considered by the investigator to be related to the study vaccine, and no deaths were reported during the study. That was the safety profile. Next, we coming to the immunogenicity. For the 13 PCV serotypes, the baseline OPA GMTs were generally numerically highest in those participants with the prior PCV13 and PPSV23. So what it means that people who had previously got the PCV13 and PPSV23 had a better opsonophagic activity with their titers really high, and were lowest with people who had only gotten the PPSV23 alone. 1 month after single dose of PCV20, the OPA GMTs were generally numerically highest in the cohort of participants with PCV13 only and lowest in those participants with PPSV23 only. So coming to the conclusion of this study, the safety and tolerability profile of the PCV20 was similar among adults more than 65 years of age with different pneumococcal vaccine histories, and was also similar to the PCV13 and PPSV23 control groups. PCV20 elicited robust immune response to the 13 serotypes and even more robust response to the 7 additional serotypes in individuals who previously received pneumococcal vaccinations. These data support the use of PCV20 as a safe vaccine that may provide protection against the 20 vaccine serotypes in older adults previously vaccinated with various pneumococcal vaccines. Furthermore, these data indicate that PCV20 could be preferred choice as an alternative to revaccination with PPSV23 in circumstances where revaccination should otherwise be indicated. So till now, like I said, in India, we start a patient with PCV13 followed by the PPSV23. So now, since the arrival of the PCV20, this is going to change. So from now onwards, a single dose of PCV20 should be enough. Then there is no need for any revaccination or any booster dose vaccination. You can just give up the pneumococcal PCV20 vaccine and finish it off with that. So I took this paper because it has just been released in India, and I think in the following weeks, most of the hospitals will start getting the PCV20 vaccine. Next one is a very important topic. It is basically the effect of BCG vaccination against Mycobacterium tuberculosis infection in children. It is a systematic review and meta-analysis. This was done in China and it was published in the IGID, International Journal of Infectious Diseases, in 2025. So, as you all know, in a country like India, TB is one of the greatest villains of our time, and unless otherwise proved, it is always TB. That is what we see in our clinical practice. So we've all gotten the BCG vaccination, but even then we still keep having recurrences of TB. So this is actually done in children. So effects of BCG vaccination. So like again, TB remains the leading cause of infectious morbidity, mortality among children worldwide. There's a huge mortality. And why in children is basically due to the developing immune status. Infants and children younger than 5 years are at an even more susceptibility for the infection, highlighting the risk of TB progression. After being infected with the Mycobacterium tuberculosis, some individuals develop. So this is one important factor that we have to know. So when the TB enters the body, some people they develop active TB, while the majority remain in a state of latent tuberculosis infection. So that is LTBI, or otherwise known as latent TB infection. Latent TB infection later in life progresses to the TB disease. So this is characterized by a sustained immune response of Mycobacterium tuberculosis antigen without clinical manifestation of active TB. Individuals with LTBI are at a risk of progressing to active TB. So you must have all heard of the Manto test, the IGRA test. So what this does, it detects latent TB. It does not detect active tuberculosis. So that is an important point. So so people come to you with outside reports of a Manto being positive. So that does not mean that they have active tuberculosis. A positive IGRA or a positive Manto means that they are having latent tuberculosis, and latent TB actually requires treatment. WHO has actually asked to start treatment for latent TB. Why is that? If it does not get treated, they will progress to active TB disease in the future. Therefore, detection and treatment of latent TB are crucial for the elimination of TB disease. So the BCG is the only vaccine licensed to prevent TB and has been included in childhood immunization programs in many countries with approximately 100 million newborns vaccinated every year. So studies have shown that BCG is 60 to 80% effective protecting children from severe TB, especially TB meningitis. However, until recently, it was unclear whether the BCG's protective effect against disease stems from its effect in preventing infection or is limited to preventing infection from progressing to active TB. So advancement in T-cell based interferon gamma assays, that is IGRA, have enhanced the accuracy of detecting MTB infection and can distinguish Mycobacterium tuberculosis infection from BCG vaccination and most NTM infection. This innovation provides a promising avenue for evaluating BCG's effectiveness against infections. So in 2014, Roy et al., he evaluated the effectiveness of BCG vaccination in children under 16 years of age who had recent exposures to active TB using the IGRA test. So the IGRA test is similar to your MAN2, but it is a blood test. So what it does, it detects latent TB. This does not become positive just because you've taken a BCG vaccination. So if your IGRA is negative and later after a period of time if it becomes positive, definitely there is a conversion. You've had latent TB infection. So this study, that is the Roy et al. Study, had only 14 studies. So this study's objective was to reevaluate the protective effect of the BCG vaccine in children under 19 years of age who were exposed to Mycobacterium tuberculosis. So inclusion criteria for the study was children under 19 years who had exposure to people with active TB, divided participants to receive BCG and non-BCG, and they were screened with IGRA. Exclusion criteria involved children who were immunosuppressed or on any immunosuppressant and assessed BCG vaccine based on self-report or did not state the method of assessment, used non-commercial or modified IGRA, selected individuals solely based on TST positive results at baseline, your abstract, letter, case reports, review success. So those were all excluded. So they identified 2,976 eligible papers, and after removal duplication, 2,319 papers were screened by their title and abstract. From this screening, 457 text paper review and 32 articles were included in the analysis. One was non-English, 19 out of the 32, 19 were conducted from a low TB incidence area and 13 from a high TB incidence area. So that is an important thing. They've actually checked from two areas, that is a low TB incidence area and 13 from high TB incidence areas. BCG vaccination status was assessed either by the BCG scar or medical records from the medical records. So what they found out was that in low TB incidence areas, the findings indicated 37% protective effectiveness of the BCG vaccination against infection and 66% against active TB, against progression to active TB. In high incidence area, the results demonstrated 55% protective effectiveness of BCG vaccine against progression to active TB. The findings indicated a 35% protective effectiveness of BCG vaccination against active TB, indicating a non-significant result. However, the BCG vaccination did not show a preventive effect against infection. The overall protective effectiveness of BCG against infection was 18% with a relative risk of 0.8. Subgroup analysis revealed a higher effectiveness of 29% in low TB areas, while effectiveness was not significant in high TB areas. So basically what the study actually came out was that BCG vaccination protects against Mycobacterium tuberculosis infection with effectiveness varying by TB incidence. So it basically depends on the area in which you're from. It showed a 29% protective effect in low incidence areas, but no significant protection in high incidence areas. These results highlight the need to consider regional TB incidence in vaccination strategies and call for further research to improve TB prevention, particularly in high incidence areas. So actually, there was a study being underdone by the ICMR in our country in Delhi, but currently it has been suspended. Why is because there was a recent article in the NEJM which was published in May 2025. It's basically was actually to see for BCG revaccination to prevent Mycobacterium tuberculosis infection. So this was done in adults in South Africa, but what they concluded was that BCG reactivation in quantiferon test negative adolescents was not shown to provide protection from sustained Mycobacterium tuberculosis infection. So finally what it is that BCG is not a great vaccine to prevent us from getting the disease. So we still have a long way to go in terms of protections against tuberculosis. The next one, the next study that I've taken is from the Lancet, published in January of this year. It deals with a very important topic, is the HPV vaccination against high-grade cervical lesion by age and dose. It's a population-based cohort study. So endometrial malignancy is a huge disease which is vaccine preventable. So, published this year. Cervical cancer, the fourth most common cancer among women worldwide in 2022, which is a completely preventable disease. So, as such, the WHO global strategy aims to eliminate cervical cancer within the next century by scaling up preventive strategies, including HPV vaccination, screening, and treatment of pre-cancer stage. Since the approval of HPV vaccine 2006, HPV vaccine has been introduced as part of national immunization services in 143 countries worldwide. An initial approval, all HPV vaccinations were administered through a 3-dose regimen. However, the WHO later changed it to follow a 1 or 2-dose schedule to facilitate global vaccine access and to eliminate cervical cancer. To date, 53 countries have switched to a single-dose program, while the rest remain using a 2-dose schedule in their program. It is not in our immunization program, but we give 2 or 3 doses depending on the age at which we vaccinate them. So, recently 2 randomized controlled trials conducted in Africa had demonstrated comparable immunogenicity and efficacy against the HPV infection. One of those compared to 2 or 3 doses in girls aged 9 to 20. So the age is quite important here. Before the first sexual intercourse is what we are actually aiming. So ideally they have to be vaccinated between 9 to 14 years of age. However, evaluating disease endpoint efficacy typically requires a long follow-up and large sample state, which are often impractical in trials. So, to their knowledge, no randomized trials to date have evaluated the efficacy of reduced dose vaccines against pre-cancer stage outcomes or cancer itself. Additionally, trials may lack the power for subgroup analysis, such as lower dose for older women. On the other hand, some observational studies have found a comparable effectiveness of reduced dose vaccine against pre-cancer lesions in young people. So what they've done is actually here, a meta-analysis concluded that there was a high degree of heterogeneity among these studies, which reduced the reliability of current evidence. So in this population-based study, we aim to comprehensively evaluate the effectiveness by age at which vaccination and doses in preventing high-grade cervical lesions 17 years after the introduction of the HPV vaccine using high-quality data from nationwide Swedish register. So here they are looking at 2 things. One is the age at which they have been vaccinated. Second is the number of doses that they've got. So from this cohort, how they've done it, they've taken around 22 lakh females aged 10 to 35 years who are residents of Sweden and between living from 2006 to 2022 sorry, and receiving at least 1 dose of quadrivalent HPV vaccine. And they've used possession regression model to estimate the incidence rate ratio, comparing the incidence rate of high-grade cervical lesion in relation to age at vaccination and the dose. So like I said, it's a very big study, 22 lakh girls from 10 to 35 years with a median follow-up time of 10 years. So around 5 lakh girls and women received at least 1 dose of quadrivalent HPV vaccine, out of which 8.3 had received 1 dose, 40 had received 2 doses, while 51 had received 3 doses. When stratified by age at vaccination, 69% had received their first dose before 15 years of age. During the study period, there were 71,000 and 10,000 cases of high-grade cervical lesions among the unvaccinated and vaccinated. So as you can see, 71,000 incidents of high-grade lesion among the unvaccinated and 10,000 among the vaccinated group. So among the girls and women who received at least 1 dose of quadrivalent HPV vaccine, the overall relative risk for high-grade cervical lesions of comparing vaccinated participants to unvaccinated participants was 0.6. While stratified to age at vaccination, the fully adjusted relative risk of vaccination from 10 to 14 were 0.5, 15 to 16 was 0.6, 17 to 20 was 0.9. When stratified by number of doses received compared to unvaccinated, the overall fully adjusted relative risk of 1, 2, and 3 doses were 0.7, 0.7, and zero point 0.5 respectively. So when examined by age at first vaccination and the number of doses received during the study period, we found a reduced risk of high-grade cervical lesion among women who were initiated vaccination before 17 years, regardless of doses received compared with the unvaccinated. So that is important. So they found a reduced risk of women who got the vaccination before 17 years, regardless of the number of doses. So that is quite important. Regardless of the number of doses, those who got the vaccination before the age of 17 had a very reduced risk of high-grade cervical cancer. And also, we observed the relative risk of 0.4, 0.5, and 0.5 among girls vaccinated with 1, 2, and 3 doses before the age of 15. While those among vaccinated at age 15 to 16, the reduced risk associated with one dose was comparable with that associated with 2 or 3 doses. For women initially vaccinated before the age of 17 and 20, the relative risk of 1 dose and 2 doses were similar, while the relative risk of 3 was 0.64. Among females vaccinated after 20 years, only those who had 3 doses had a statistically significant lower incidence of high-grade cervical lesions. So that is also important. So after the age of 20, only with 3 doses did they have a statistically significant lower incidence of high-grade cancers. So receiving 1 or 2 doses of HPV vaccines prior to the age of 17, especially for those initiating before the age of 15, has comparable effectiveness against high-grade cervical lesion with those who received 3 doses. In conclusion, the quadrivalent HPV vaccine has continued to demonstrate remarkable effectiveness in preventing high-grade cervical lesions up to 17 years after the introduction of HPV vaccination. Receiving 1 or 2 doses of HPV vaccination prior to the age of 17, especially for those initiating before age 15, has demonstrated comparable effectiveness with those who received 3 doses, which supports the WHO's current recommendation of using 1 dose HPV vaccine regimen in adolescents. So that was regarding HPV. The next important paper that I've taken is actually related to malaria. This had actually from the Lancet, which had come out in February 2024. As you know, malaria is one of the major diseases with a global mortality and morbidity with more than 6 lakh 20,000 deaths annually. So as you know, recently the WHO had given away with the RTS vaccination, which is to be given in children living in regions with moderate to high malaria transmission, the RTS SAS01. So in the phase 3 trial, vaccine efficacy in children age 15, children age 5 to 17 months with the 4-dose regimen was 56% over 1 year and 36% over 4 years. So it's a start actually. So it is basically given to children from 5 months to 17 months. It's actually a 4-dose regimen. So after 1 year, there was around 56% efficacy, and after 4 years was 36%. So the RTS has actually again been remodified, and now it is actually the R21. It differs from the RTS that the HBsAg molecules are fused to the NANP repeat and C terminus of the circumsporozoid protein. So the study actually previously reported the 24-month efficacy of 75% and 77% for time to first episode and multiple episodes of clinical malaria, respectively, with 4 doses of the newer R21 matrixam in children aged 5 to 17 months at a center in Africa, Burkina Faso, in the phase 2 study. So in this multi-center study, double-blind randomized phase 3 trial, what they've done is actually to assess the safety and efficacy of the R21 matrix M vaccine. So in this study, they've actually taken the R21 matrix M vaccine, and it's a multi-centered study, phase 3 study. And here what they've done is in the extended age group of, before it was 5 to 17, this is 5 to 36 months of age at the first dose rather than 5 to 17 months. So they've actually extended the age group. So double-blind randomized phase 3 trial of the R21 matrix across 5 sites in 4 African countries. And there also it also differs from the malarial transmission intensity and the seasonality. Children 5 to 36 were enrolled and randomly assigned 2:1 to receive either the matrix M vaccine, or the control was the Abairab rabies vaccine that was just given as the control. And vaccines were administered as a 3 doses 4 weeks apart, with a booster administered 12 months after the third dose. Half of the children were recruited at 2 sites with seasonal malaria transmission, and the remainder at standard site with the perennial malaria transmission using age-based immunization. The primary objective was protective efficacy of the matrix M vaccine from 14 days after third vaccination to 12 months after completion of the primary series at the seasonal and standard site separately as co-primary endpoints. Vaccine efficacy against multiple malarial episodes and severe malaria, as well as safety and immunogenicity, was also assessed. This is still undergoing. So it's a huge study. There from April 2021 to Jan 2022, 5,477 children consented to be screened, of whom 1,705 were randomly assigned to control vaccine, and 3,434 received the matrix M vaccine. 3,103 participants in the matrix M group and 1,541 participants in the control group were included in the modified per protocol analysis. So the matrix M R21 vaccine was well tolerated, with injection site pain as the most frequent adverse effect. The number of adverse events to special interest and serious adverse events did not significantly differ between the vaccine group. There were no treatment-related deaths. 12-month vaccine efficacy was 75% at the seasonal site and 68% at the standard sites of time to first clinical malarial episode. Similarly, vaccine efficacy against multiple clinical malaria episode was 75% at the seasonal site and 67% at the standard site. A rate reduction of almost 868 cases per 1,000 children at seasonal site and 296 at the standard site occurred at 12 months. So that's actually a very significant finding there. High specific antibody titers were observed in the 5 to 17 month age group compared to 18 to 36 month age group, and the younger age group had the highest 12-month vaccine efficacy on time to first clinical malaria episode at seasonal and standard site. So from this study, the newer R21 matrix M is well tolerated and offered high efficacy against clinical malaria in African children. This low-cost, high-efficacy vaccine is already licensed by African countries and recently received a WHO policy recommendation pre-qualification, offering large-scale supply to help reduce the great burden of malaria in sub-Saharan Africa. It is still not available in India, but maybe in the future it will come. Sorry. Another important disease which is resurfacing again is pertussis. This study is a review article. It's come in the Indian Journal of Medical Microbiology. It had come out in 2025, and the primary author is from CMC. So pertussis, as you know, otherwise whooping cough, is a highly contagious disease, and it was one of the leading cause of mortality in the early 20th century. Then we had the whole cell pertussis, which was developed in 1914. Then I combined with the diphtheria and tetanus. So that is the DTP, and it started in 1939, and it reducing the cases by 75%. So the vaccine became widely adopted as a DTP combination in 1940s. However, because of the wholesale side effect, such as febrile convulsions, inflammatory reactions, it led to the development of the acellular pertussis vaccine in the late 1990s. Sorry. high-income countries adopted the acellular pertussis, while most of the low and middle-income countries continued using the whole cell pertussis due to cost considerations. So then what happened? There was a global pertussis resurgence. Over the past 20 years, despite high vaccine coverage, many high-income countries that switched from the whole pertussis to the acellular pertussis have seen cyclical re-emerging of pertussis outbreaks, with cases shifting from infants to adolescents and adults due to the waning immunity and insufficient cocoon immunity. Soon, increasing pertussis cases were reported from the whole cell pertussis countries as well. So WHO estimates that 90% of global pertussis cases are from the low LMIC, and it was in conjunction to poor vaccine coverage. India reported 3.6 million cases, and China saw an increase from 0.13 per thousand in 2013 to 2.15 per lakh in 2019, with over 58,000 cases as early as 2024. So as you can see, there's a huge jump in that. In Europe also, despite high vaccination coverage, pertussis research cyclically every year 3 to 5 years, with over 32,000 cases by March 2024. Another important issue is that it exhibited macrolide resistance also up to 90%. So that is also a very scary situation. So India's national program, the DTP came, the wholesale vaccine was introduced in 1978 under the Universal Immunization Program. Currently, we follow the 3-dose, 6, 10, 14 weeks with 2 booster doses at 16 to 18 months and 4 to 6. The IAP also recommends the acellular at 10 years, and in circumstances where Tdap is unavailable or affordable can be substituted. While WHO recommends more than 90, India reports average of 89%, with most districts exceeding more than 90. However, the booster immunization data remains inconsistent or low. Despite 40 years of high wholesale pertussis coverage, India accounts for 26.5% of global pertussis cases, potentially due to waning immunity, inadequate booster coverage, and circulation of vaccine escape Bordetella pertussis strains. This highlights the need for active surveillance, evaluation of waning immunity, and genome-wide studies to assess the emergence of vaccine-derived strains. Sorry. Another important entity here is linked epitome suppression. So this is actually why the acellular pertussis is not shown a great effect. The linked epitome suppression is an immunological phenomenon observed in individuals vaccinated with the acellular vaccine. What happens? It occurs when the memory B cells generated in response to limited antigens in the acellular pertussis vaccine outcompete the naive B cells for access to epitope from circulating Bordetella pertussis. This happens because memory B cells are more numerous and have higher antigen affinity. So as a result, when the immune system prioritizes its response to specific antigen it has been exposed to before, thereby suppressing its ability to mount an effective response to new antigens encountered later. So this mechanism plays a crucial role in explaining the inferior performance of the acellular vaccine compared to the whole cell vaccine in providing long-lasting immunity. And this explains why the DT acellular pertussis vaccinated people become permanently susceptible to the Bordetella pertussis that differ antigenically from the vaccine strain. So here what they've done is they've information was obtained from PubMed, Medline, Google Scholar, and particular attention was also given to genomic surveillance, epidemiology data, genetics, and immunological sites from global and Indian contexts were reviewed. So they've gone through most of the cases in which there are variants which have actually caused the resurgence. There are multiple studies. I'll just go through that. There's a Swedish study, Spanish study, Australian study. All it showed is actually the acellular pertussis is actually performing very poor as compared to the whole cell vaccine. So despite high wholesale vaccine coverage, India accounts for 26.5% of global pertussis cases, driven by the waning immunity, low booster uptake, and spread of the vaccine escape PTX P3 strains. The emergence of macrolide resistance further challenges disease control with selective pressures influencing genetic shifts in pertussis. While whole cell vaccine provides long-lasting immunity, Acellular vaccine offers short protection and induce linked epitome suppression, contributing to the resurgence of pertussis. So DTP currently in adults, we actually advise them to get DTP once every 10 years so that this issue is actually sorted out. So, yeah, conclusion. Yeah, so it's basically said despite high vaccination cover in India, there remains a significant pertussis burden, particularly among 10 to 15 years of age, underscoring the need for booster doses for adolescent and reevaluation of vaccination strategies. The coexistence of the whole and the acellular pertussis vaccines for the primary series and booster dose in children complicates the situation. But to prevent pertussis outbreak, robust surveillance system must be implemented to monitor cases and evaluate protective immunity. Enhanced surveillance and targeted booster vaccinations for adults and adolescents are essential to effectively address the ongoing challenges posed by pertussis. My another important review article that I've taken is actually from the journal Viruses. It's actually by Dr. Govindaraj from the Department of Infectious Disease Immunology from University of Florida. It has come up in the Viruses journal. Why I've taken it is because dengue, as you all know, is so rampant in our part of the country. So this paper actually gives you what all are installed in the future and how to go about it. So, as you all know, dengue caused by Aedes aegypti, it's a huge issue from from this in this part of the globe. The infection results in wide range of clinical presentation from mild febrile to severe conditions such as dengue hemorrhagic fever, dengue shock syndrome, and which is fatal. Over the past 50 years, the global incidence of dengue has been there has been a significant increase with estimates indicating between 284 and 520 million people affected each year, with 96 million of these showing cases. So the WHO has classified dengue as one of the most important mosquito-borne viral diseases affecting over half of the global population, particularly in areas at risk of infection. So coming to vaccines regarding for dengue, as you all know, right now India does not have any active vaccinations against dengue at present, but I'll show you what all are installed in the future. Among the most notable advancements in recent years is the introduction of the first licensed dengue vaccine called Dengvaxia by the Sanofi company. The vaccine, approved for use in several countries including Mexico, Philippines, and Brazil, has been hailed as a significant breakthrough in the battle against dengue regarding its effectiveness and safety, especially in individuals who have not been previously exposed to dengue. However, the vaccine has also had to face challenges, particularly regarding its effectiveness and safety, especially in individuals who had not been previously exposed to the dengue virus. I'll be telling you why that statement is actually important. Nonetheless, researchers have pursued alternatives and safety, especially in individuals who have not been previously exposed to avenues of dengue vaccine development, including live, attenuated, inactivated, and subunit vaccine. So these are the different vaccine prototypes. You have the live attenuated uh, the different vaccine models. You've got the live attenuated model, then you have the inactivated vaccine, you have vaccine like particles, you have subunit vaccines, you have viral vector vaccines, and you have DNA based vaccine. The recently developed Sanofi's Dengvaxia is the first commercially licensed dengue vaccine consisting of a tetravalent formulation. Despite being recommended and administered in multiple countries, Dengvaxi has shown severe adverse side effects and low effectiveness. We'll talk on that. Ongoing efforts include the development of new strategies such as the Takeda Biologics TAG003 vaccine, which has been granted priority by the US for the prevention of dengue diseases caused by all four dengue virus serotypes. So, coming to live attenuated vaccine. So there are three major live attenuated vaccines which are currently being developed. The live attenuated vaccines are made up of the weakened forms of living pathogens that have been altered to be less harmful or non-pathogenic. These forms of vaccine offer the advantage of delivering a range of protective antigens and provide long-term immune protection. Several vaccine formulations are at different stages of development at various organizations. So far, only one has been licensed for use, and the others are in clinical trials. So I'll be talking about Dengvaxia by Sanofi. That is the only one which is actually licensed. So this is actually a chimeric yellow fever virus, dengue virus, tetravalent virus, also known as Dengvaxia, first licensed by the Sanofi company. So what happened is it was actually allowed for to be given to people aged 9 to 45 years, and it is a subcutaneous injection with 3 doses offered 6 months apart. So the dengue risk may be affected by the patient's base. So what happened is they had started the study in the Philippines, and later they found out that lots of children, after getting the vaccine, when they got the disease, started having serious complications. There were actually around 14 deaths which have been linked to the vaccine, but they've not been able to confirm it. So what actually happens is, suppose a patient has not had dengue and they're taking the Dengvaxia for the first time. So the body treats it like the first dengue infection. And then when they actually get the dengue vaccine, because of an we'll be discussing on that, because of the antibody mediated issue, the body actually fights against it as in the severe form. So what happens is dengue risk may be affected by the patient's baseline serostatus, and the vaccine may cause severe dengue in seronegative patients through antibody dependent efficacy. It has been approved in some countries but can only be used in people who had dengue before. So before you give this vaccine, now you have to make sure that they've already had the dengue before. You should not, it should not be given to a person who's not had the dengue disease. A subsequent report found that seronegative people have a higher risk of hospitalization and severe dengue, with a proportional hazard ratio of 1.75 for hospitalization and 2.87 for severe dengue, contrasted with corresponding of 0.3 and 0.31 in seropositive patients. So as you can see, when you compare people who have already had the disease and people who have not had the disease, there's a higher hazard ratio. So the WHO suggests pre-immunization evaluation sorry, for considering the vaccination, and to be given to only seropositive people with a confirmed past dengue infection, or in regions with reported seroprevalence of approximately 80% by 9 years old. So that was a major issue of the dengue vaccine. It can only be given to people who have already had the disease once. So that is the only vaccine which is licensed currently. And the other two vaccines which are important just about to come out are the Qdenga or the TAG 003. It is produced by the Takeda Pharmaceuticals. It's live attenuated tetravalent vaccine. It is based on the dengue virus 2 vaccine strain. So approved for use in Indonesia for individuals aged 6 to 45, as well as marketing authorization in the European Union for people aged 4 years or older, regardless of their previous dengue infection. So that is an important thing here. Their past history, whether they've had a dengue or not, is not important. Administration of this disease caused by all for dengue virus. Notably, the vaccine offers highest protection against the dengue virus type 2. Sorry. The vaccine is administered as a 0.5 ml dose with 2 doses scheduled with a 3-month interval. Very sorry. The third important vaccine, that is the live vaccine, is the TV003 or the Butantan vaccine, actually developed by the National Institute of Allergy and Infectious Diseases, currently in phase 3B clinical trials. Live attenuated vaccine is a single dose and could achieve seroconversion rates between 64 and 100%. The Butantan Institute in Brazil has been authorized to produce the liposome it is known as the Butantan DV. It's a single dose vaccine showing 80% among participants with no evidence of previous dengue exposure, and 89 with a past history, with a past exposure of dengue. So that's a huge promising study. Overall, the 4 vaccine strain against type 1 dengue was 0.9. Vaccine efficacy against the type 1 dengue was 96% and 95 among seropositive, and among seronegative was 83 and 57. Dengue serotypes 3 and 4 were not circulating in Brazil at that point of time. So that is actually, they do not know about it. The other different vaccines that are in the lineup are your DNA vaccines, subunit vaccines, viral vector vaccines, virus-like particle vaccines, the mRNA vaccines, and the inactivated virus vaccine. So why I took this actually, because we deal with dengue almost on a daily basis. So once a vaccine comes, it is going to make a huge change for us. So we have to know what are the expected changes and vaccines that are about to come. So the FDA approved vaccine, only dengue vaccine, is effective only in individuals aged 9 to 16 who have previously contracted dengue. So that is an important thing. Dengue vaccine can only be given to people who already had the dengue disease in the past. And the TV03 is emerging as a leading contender because it demonstrated robust neutralizing antibody responses, successful seroconversion of all 4 serotypes, and the benefit of a single dose regimen, making it viable option for implementation in developing countries. So maybe in the future, this is what we would also be getting. So this is what the future for dengue looks like. So this is my last paper. What this is a huge paper. Why? Because we treat a lot of HIV patients. So as you know, once you have the disease, very sorry. So once you the diagnosis of HIV, it's a life-changing diagnosis. You know, it's a huge but issue for the patient, because then they will have to be on lifelong medication. So always there has been the question: is there, can't we make a vaccine for HIV? But with this paper, the efforts for a vaccine are actually going to come down, because they've introduced a new medication called lenacapavir. It is not a vaccine, so this is basically not a vaccine, but it does the work of a vaccine. So what they found out actually, twice a year subcutaneous injection of lenacapavir, which is a nucleoside capsid inhibitor. So lenacapavir. So what you have to do is you give it twice a year as a subcutaneous injection. So just look at the compliance. So what they've actually, so this is actually as a pre-exposure profile. So this is not once after you had exposure, this is before you have HIV. So it is a pre-exposure prophylaxis. So the current pre-exposure prophylaxis actually requires you to be on daily pills. So what this study is done is it is actually compared two things. One is daily emtricitabine tenofovir, that is your FTDF tablet. So daily your oral pre-exposure prophylaxis tablet, and they've compared it to the other arm with a yearly twice subcutaneous injection of lenacapavir. And what they found out was that the HIV incidence with twice yearly lenacapavir was significantly lower than the background incidence and incidence with the emtricitabine and tenofovir drug. So as you can see, it's a huge study. So once this comes in, this cannot be used as a treatment. This is actually for prophylaxis. But yearly 2 subcutaneous injection is going to replace a daily oral tablet. So this is actually a huge study. And hopefully, HIV, newer drugs are coming, and treatment is actually going to be much easier for us to do. So these are the main papers that I've taken out regarding topics which I deal with on a regular basis if you're sitting in a general medicine OPD. So I think that's about it. Thank you.
Thank you so much, sir. If the time permits, can we take 2 or 3 questions?
Yeah, sure. Yeah.
Okay, so I want to ask, how does the broader serotype coverage of PCV20 impacts the prevention of invasive pneumococcal disease in India?
the previously we had the PCV 13 and we had the PCV 23. There were certain serotypes which are not covered by the PCV 13, which is actually being covered by the PCV 20. And the 20 is a conjugated vaccine. So it has excellent coverage and memory. So you just need one single dose of the PCV 20, which covers all these strains which actually cause invasive pneumococcal disease, preventing them from getting pneumonias, meningitis, otitis media, etc. So this is actually a what you call a big change in the vaccination drive in our country. So there's no more PCV 13, then revaccination after 5. Everything goes. You just have to give a single PCV 20 and you're done with the pneumococcal vaccination. So it's a big change coming up.
Yeah, yeah. Thank you so much, sir.
Yeah.
The next question is why BCG vaccine is not routinely recommended for adults in India? And
So
is there any?
that is what I said. See, it is not
Yeah,
shown any. See, whenever for us to implement a program, it has to have results. So
yeah.
till now, the studies have not shown any results for us to implement it. But like I told you, studies are on the way. But whatever till now we had, they have not shown any promising results for us to give it.
Okay. And there are any special recommendations, special conditions where we can give it to adults?
No, right now there are no
Right.
indications for BCG in adults as till date. Now there are no indications for BCG vaccine to adults. Right now there are no indications.
Okay. And sir, regarding HPV, importance of HPV in men or boys.
Yes, definitely. That is one thing which I forgot to tell. We have to vaccinate boys that also early so that they
Yeah.
actually don't give the disease to their partners or the other sex. So them also before the age of 14 is what we would recommend.
Okay. So same age like girls or
Yes, yes,
women's.
yes, yes. It is basically
Okay.
once they start having sexual activity, it just spreads. So it is actually before,
Yeah.
I'm very sorry, before they have their sexual, this one we have to vaccinate them.
Yeah. And sir, do you routinely use the malarial vaccines in your
No, no.
practice?
We don't have malarial vaccines in India as of now. These are all being done in very high burden areas in the sub-Saharan Africa. We don't have
Yeah.
malarial vaccines in India for now, but it will come.
Hmm. Okay. And my last question is, what is current regularity status of a lenacapavir in US for HIV prevention?
Mm-hmm. I've not used this. This is just the study just came out in April of 2025. So
Okay,
what I've understood that it is going the price and all is going to be an issue, but
right.
it's completely changed the picture. See, twice yearly an injection which would prevent a such big disease is actually a big thing. Excuse me.
Yeah, right.
I'm very
And
sorry.
there is
So
a long way to come this in India, right?
definitely, but it will come. The study is still going on. But so when you have something like this, they work on it and make sure that it comes out.
Okay, okay. Yes, thank you so much, sir. Thank you for your
Sure.
presenting a top papers and enlighten us with your insights. Your session was truly valuable and inspiring. Thank you so much, sir.
Thank you for allowing me to present the papers. Thank you.
Yeah, thank you so much, sir.